Hey guys, today's lecture is on retinoblastoma. Retinoblastoma is an eye cancer which begins in the retina. It could be hereditary. There are two types: hereditary, could be hereditary or non-hereditary. Right? If it's hereditary, let's talk about the genes. Let's talk about the mutations. What is happening if it's hereditary? Actually, the mutation is there on the RB1 gene. The gene name here is RB1. You can easily remember retinoblastoma. So RB1, this is the gene name. Yes, RB1 gene is actually a tumor suppressor gene. Okay, so why it's important to know? Because tumor suppressor genes are responsible for the normal development of the tissues, because they are just like a brake. Whenever there is a cell reproduction or growth is in process, in that case they can just stop the growth. They can control the cell reproduction. But if there is a mutation, if this gene is not working, it means there will be uncontrollable growth of the cells and there will be formation of a tumor. And on the RB1 gene, what is the mutation? Actually, there is a deletion. And this deletion, what's the location of this deletion? This is 13q14. Okay, remember this. Now, there could be three types of the retinoblastoma. One is unilateral, in which there is just one-sided retinoblastoma in just one eye, in just one retina. Second is bilateral, of course. And third one, very special, trilateral. What is trilateral? Trilateral means when you have bilateral retinoblastoma plus pinealoblastoma, tumor of the pineal region. And this, in total, we call it trilateral. Okay? This is the most common associated tumor of the retinoblastoma. So remember the name, pinealoblastoma. It's a cancer, it will get spread, right? How can it get spread? It will get spread by what's the most common route? Most common route is a direct spread. It can directly spread through the sclera, right? So let's say this is the cancer, something like this. It's starting from the retina. Yes, retina is something like this. Yes, as in the anatomy we talked, and the retina is in incomplete layer. It's only on the posterior side. Yes, and this part is called as ora serrata, right? You remember? Okay. So it can get spread through the sclera or through the optic nerves. Yes? Okay. Through the optic nerve, if it's spreading, it can reach to the brain and it can cause cranial metastasis. That's very bad, with a very bad prognosis, right? Now, there are two types of spread. It can grow inside, like in this picture it's shown, like this, yes, or it can grow outside also, right? If it's growing inside, this will be known as endophytic. And if it's growing outside, this is exophytic. What are the manifestations of the retinoblastoma? There are three manifestations you have to remember. Let's start with the first one, leukocoria. What does that mean? Leukocoria means white pupil. White pupil. Do we have normally the white pupil reflex? No. Whenever we check with the ophthalmoscope and we put the light in the eye and we ask the child to look at the light, and we will get the red reflex. This is the normal reflex you will see here. Yes, both pupils are showing the red reflex. But here on the one side, unilateral, you are seeing the white reflex of the pupil, and that is abnormal. Okay, in the retinoblastoma, we see that, and the normal red reflex is not present in the retinoblastoma. What is the second feature? Second clinical feature is esotropia, which is a part of squint. What is esotropia? You can see here, this eye is normally looking straight, but this eye is not straight. This is looking inward. That's why it's called as esotropia. So this word, you will remember, esotropia. Tropia means when you have real squint, which is visible by the eyes. Okay. When you have pseudo strabismus, in that case you call it phoria, not the tropia. This can be checked by Hirschberg test, in which we'll be putting the light pen test, just the normal a light will be put in the eye, and if the light, you can see here, so we have got reflex here, no, this white dot you can see, this is completely in the center here. It means this eye is straight. If it's not in the center, let's say in this one, here it's not in the center of the pupil, it means this is outside, no, the pupil, it means it's outside. Wherever it's outside in the Hirschberg test, it means the tropia or the strabismus is opposite to that. So the direction is opposite to that. It means this is isotropia. So it means the eye is inside. If the light is going outside, it means the eye is inside. That will be confirming your diagnosis. Of course, this is very clear in this TB. It's completely clear that this eye is inward, but in some cases that there is a very minor difference between both of them. Both of the eyes. In that case, we can do the Hirschberg test to confirm the strabismus. And the third most common sign is ophthalmos due to secondary glaucoma. Okay, secondary glaucoma. You can see these both eyes are very big in size now. There must be eyeball must be enlarging, or this eye is coming out. You can see that, but this is due to secondary glaucoma. Glaucoma means there is a optic disc degeneration as well. There could be increased IOP. As you can see in these photos, the eye is completely like abnormal. You can directly see and tell that this is ophthalmos. So in the babies, you will see babies with the retinoblastoma. You will see this eye is you can see ophthalmos with the ophthalmos. So these three were the very important signs in the retinoblastoma: leukocoria, isotropia as a squint, and your secondary glaucoma. How can we diagnose the retinoblastoma? You see, there are some tests, investigations we can do. First one is X-ray. X-ray we are doing because there is a calcification. Always retinoblastoma is a very major cause of calcification in the ocular department, and you will see the calcification on the X-ray. That by that you can guess. But for that you have to do the further tests such as CT, MRI. Because CT and MRI will show you the metastasis in the intracranial parts or in the what is the extent of the disease, right? But what is the gold standard thing you have to do? That is your biopsy. Without biopsy, never we can diagnose a cancer, and we can't tell what type of cells are there and which type of cancer is this, right? So biopsy would be the your gold standard. Okay, let's talk about these photos. You can see the calcification, this tumor here. And we can see the tumor here, as we can see the calcification also here. And on the posterior side also, you can see it's not the normal optic disc. There must be the metastasis. Okay. We are taking the biopsy. As I have told you, this is the most important and gold standard diagnostic investigation. But from where we are getting the sample? We are getting the sample from the optic disc. From the optic disc. Because that's the parts of, in general, optic nerve I can call it. So it will be better. Optic nerve, I would say. From the optic nerve, I will get the sample, and through that I can get the extent of the disease, and I can get that if this disease is positive. Let's talk about the biopsy findings. We have got rosettes in the biopsy. Whenever we see whenever we see the cells out there, there are some formation of the rosettes. And how we can tell which rosettes are there and what are the types? Actually, we have got three types here in the pathology. The first one is your true rosette. This is a pathognomic rosette, which is very specific for the retinoblastoma. The name is Flexner-Wintersteiner rosette. Flexner-Wintersteiner rosette. Next is why they are different from each other. Just see the photos. You can see a lumen in the Flexner-Wintersteiner, but you can't see any lumen in the Homer-right. In the Flexner-Wintersteiner, there is a lumen which is formed by the cell borders, and there are cytoplasmic extensions, but there is no basement membrane. And you are seeing a true lumen. That's why this is a true rosette. But the Homer-right and the Fleuret's rosette, they both are pseudo-rosettes. They both are pseudo-rosettes because we don't have the true lumen there. In the Homer-Wintersteiner, you can't see anything at all. What you see is all that is the interwoven cytoplasmic processes of the nerve fibers and the neuroglial cells, but there is no lumen. In the fluorid rosette, this is a pseudo rosette. Why? Because you are seeing whatever it's in the red. This is a blood vessel. So there is these tumor cells. So these are the tumor cells. Whatever these are the tumor cells, right? And the tumor cells are around the blood vessel in the fluorid rosette. That's why this is again the pseudo rosette. What's the most important and most specific and pathognomic for the retinoblastoma? This is flexner with the pseudo rosette. This is most important one. But these are also seen in the retinoblastoma, but they are not pathognomic. In the international retinoblastoma staging system, there are 5 stages of the retinoblastoma. These are stage 0 to stage 4. Stage 0 is when the tumor is in the eye only and the eye has not been removed and the tumor was treated without surgery. Actually, this system is depends on how much cancer remains after the surgery to remove the tumor and whether the cancer has spread. Stage 0 is this. In the stage 2, again, the tumor is in the eye only and eye has been removed and no cancer cells remain. Stage 2 means the tumor is in the eye only and the eye has been removed and cancer cells remain that can be seen only with the microscope. Stage 3A, it has cancer is spread from the eye to the tissues around the eye socket. And the cancer has spread from the eye to the lymph nodes in the ear, in the neck. That's the stage 3B. Stage 4A is about cancer has spread to the one or more parts in the body such as bone or liver. And stage 4B means when the cancer has spread in the brain or spinal cord. As you may have guessed till now, the treatment of option, the treatment of choice for the retinoblastoma, that is, eye has been removed. It means enucleation. Enucleation, what does that mean? When we are removing the complete eye wall with the optic nerve cells. So we are removing everything out. That is called enucleation. That is the treatment for this retinoblastoma. Plus we are giving the chemotherapy because we want to kill the minor cells also, where whatever is left there. And if there is some metastasis also, then also we are treating that, and then we are we are killing these cells with the chemo. Which are the drugs specifically we are using for the retinoblastoma? These are vincristine, carboplatin, and etoposide. I would to add a special note at the last. As you have learned here in the 4th B, so the cancer can spread in the 4A and 4B, actually, the bone and liver and the brain and spine. So it can spread anywhere in any part of the body. Yes, and the most, remember it, most common secondary metastasis, actually secondary tumor, I would say, due to metastasis of this. We are saying it's secondary because it is due to metastasis, and this is secondary tumor, associated tumor with the retinoblastoma, that is osteosarcoma. Osteosarcoma, and it's important. So whenever the question comes from this, they can ask about the most common secondary metastasis, that is osteosarcoma, and what is the most common associated. If it's hereditary, I've already told you. If it's tertiary retinoblastoma, in that case we have bilateral retinoblastoma with pinealoblastoma. Yes, and this that was the condition which is associated with that, and this is secondary due to metastasis. But pinealoblastoma was just associated with that, but that was not due to metastasis or something. They were different, but they were together. Here it is due to retinoblastoma metastasis, and that's why this is second. Now at the end, answer some questions with me, and you will get to revise the whole video, the whole lecture on the retinoblastoma. Let's start with the first question. Most common primary ocular malignancy, this is retinoblastoma, right? And most common clinical feature of the retinoblastoma, do you know? Can you answer? This is leukocoria, right? Leukocoria, the white reflex. Okay, what is the pathognomic biopsy sign of the retinoblastoma? Do you remember? That was flexner winter-steamer or right? Okay, What is the gene in the hereditary location? What's the location of the hereditary retinoblastoma? That was RB1 gene, and the location was 13q14. Okay, what was the type of mutation? That was deletion. Okay, most common associated malignancy and most common associated secondary malignancy. Associated malignancy was pinealoblastoma, and your secondary malignancy was osteosarcoma. Okay, what's the treatment of choice in the retinoblastoma? That is enucleation. Good.